make sure that everyone in our state knows how much more we could do to prevent cervical cancer in our state, around the country, and around the world. We have made so many advances in the last 20 years, and yet I think most people still will tell you that a pap smear is the best way to prevent cervical cancer, and that's just simply not true. If you didn't know that, then I am so glad that you are here at this talk today. It looks like we're just over 60% on the poll. I'll give you a little bit more information about my background. I am originally from South Carolina, born and raised. I did my medical school at MUSC in Charleston, South Carolina, and then residency in OB/GYN at the Brigham and Women's and Massachusetts General Hospital up in Boston, a Harvard-affiliated hospital, and then the UVA, Virginia for fellowship in GYN oncology, and then was on faculty at MUSC in Charleston for 8 years before coming here. In that time, I have served in various positions, both locally, regionally, and nationally, to do with HPV vaccine uptake and cervical cancer prevention. So it really has been a lifelong passion of mine that started the day I entered fellowship, was the day that FDA approved the HPV vaccine. And it's been an uphill battle since then that I think we're all now seeing with the COVID vaccine. Just because we have a safe and effective vaccine doesn't always mean that people are willing to take it. And so that burden as healthcare providers or students in public health, or wherever you find yourself on the spectrum as a parent or a friend of someone who may eventually get vaccinated, ultimately, it's up to all of us to make sure that people make good choices and have all the information they need to protect themselves and their families from this deadly virus. And no, I'm not talking about COVID. So with that, I guess I'll go ahead and end the poll. We're not quite at 5 minutes, but we've been stable at 60% for a while now. And I'm not going to tell you the answers till the end. Oh, poll has ended. Should I share the results real quick? Can everybody see those poll results? So just quickly, when should women begin cervical cancer screening? At age 21 was 50%. That was the most common answer. Pap tests are just as good at preventing cervical cancer, so there's no need to vaccinate, was false, 92%. Oh, we're done. I don't even need to give this talk. What are the symptoms of cervical cancer in the early stages? Typically, there are no obvious symptoms at 88%. Great job. Boys and girls are already sexually active, so they don't need the HPV vaccine, is false. What are some reasons parents don't vaccinate? All of the above. And it looks like there's a little bit of learning to be done. Nope. Early detection of cervical cancer increases women's survival rate, and true in almost all women if they're seen and treated early. So fantastic job. We'll just stop right here. You guys are good. So with that, we'll go through this. I hope you learned something in addition to the answers to those questions, and we'll take questions either through the chat or at the end. But hold on just a second. There we go. So just to give you an outline, we're going to review the rates of cervical cancer in Alabama, how we currently screen for cervical cancer, how we all, as healthcare providers at USA Health, can provide more services to underserved women, or if you're not in healthcare, how you could get involved in this fight, and then the prevention of cervical cancer through vaccination. So first, I want you to understand just how prevalent HPV is in the United States. Currently in the United States, we know that we have had almost 5 million documented COVID infections. In the United States, 80 million people are currently walking around with HPV. So it is much, much more common than COVID. We all know somebody who's had COVID. It is, in fact, 1 in 4 men are currently infected with a high-risk cancer-causing HPV, and 1 in 5 women are currently infected with a high-risk cancer-causing HPV. It is much higher than anyone actually suspects. And when you think about our children in college and young men and women on the dating scene, we think about that level of prevalence is why we recommend vaccination, because almost every sexually active adult will encounter HPV in their lifetime. And we're not just talking about sex. Any skin-to-skin contact can transmit HPV orally or through any other mechanism. So we know that HPV-associated cancers occur in men and women. These are not just limited to cervical cancer. They include cervix, but also include the genital skin for women, vulva and vagina, as well as anal and rectal cancers for women, penile cancers in men, and oropharynx cancers in men and women. Now, I put this relatively old slide up for you because I want you to know that when I first started doing this work in 2006, we believed that oropharynx cancer in men would outpace cervical cancer in the year 2026. And that growth rate of oropharyngeal cancer actually overpaced that, and it overcame the rate of cervical cancer in 2012. So we know that actually HPV-associated cancers in men are more common than HPV-associated cancers in women because of that oropharynx cancer. And so these cancers occur in men and women, and that's why when we look at prevention, we are going to look at vaccination in men and women. So when you look at 39,000 people diagnosed with an HPV-caused cancer in the United States, that's one case every 20 minutes. I will tell you that means that in the time that I am giving this talk over the course of today, we will get another phone call to the Mitchell Cancer Institute of another patient who is diagnosed with an HPV-caused cancer. I have been seeing patients this entire time that I've been here, stories that you would not believe, some of which we can talk more about, and we will go through some cases that are taken from all of the many patients that I've treated. Well, a little pause there. So why haven't you heard about oropharyngeal cancer until now? It used to be rare. Unfortunately, it is not rare anymore. There is a 200% increase in HPV-associated head and neck cancers in the last 10 years. That seems to be from all kinds of different reasons, but we know that it's on the rise. These are the types of cancers that occur in the base of the crypts of the tonsil or at the base of the tongue. So even your dentist is unlikely to see many of these cancers as they are forming in the very earliest stages. Unfortunately, most HPV cancers of the oropharynx are not diagnosed till they're stage 2, and one can feel a lymph node under their chin that is enlarged. And we are talking about cervical cancer today, but I can't give this talk and talk about the strive to increase HPV vaccination without talking about oropharynx cancers and why we are so stringent on also vaccinating boys. It's not to protect girls and to prevent cervical cancer, although that will be a downstream benefit, but it's directly to protect men from oropharynx cancers. So let's get back to cervical cancer. I was typing in these numbers for 2021, overlapping a slide from a few years ago, and I had to increase the number of new cases from 13,000 to 14,000, now 14,480, and I had to increase the number of deaths from 4,100 to 4,290. So I added 180 deaths to this slide from 4 years ago. That's what's happening in cervical cancer in the United States. It's a crime that we have a preventable cancer to which we have a very effective vaccine that is still on the rise. Most cancers in the United States are falling dramatically as people adopt more healthy lifestyles and move into quitting smoking and other things that we know prevent cancer, like preventative testing. And yet cervical cancer remains on the rise. We know that risk factors include not just high-risk HPV positivity, other types of immunosuppression, including diabetes, smoking, and poor access to care or no recent screening. Unfortunately, all of these problems coalesce here in Alabama to create a higher risk than usual. So cervical cancer in the United States can be deadly. It is very deadly here in Alabama. We have, unfortunately, the highest mortality in the country, and that mortality is even higher in African American women compared to white women, but it is higher than any other place in the country. We're also tied for 4th in incidence. And when I updated this slide, I had to increase that number. We used to be 5th, and now we're 4th. So our both incidence and mortality here in Alabama are on the rise, and we've got to do more to prevent these cancers. This is by county. I think it's really interesting to see where are the places that we are seeing more HPV-related cancers. It is most commonly in areas with very limited access, either no or very limited access to OBGYN services and other screening services like the F.A.C.O.Gs and other places where women can get screening and vaccination services. So screening, not just a Pap test. Let's talk about this case. This is a 32-year-old female who presented with a new Pap test. Sorry, if everybody could make sure they're muted. A new Pap test of squamous cell carcinoma. Her last Pap was 4 years ago, was atypical squamous cells showing high-risk features, or F.A.C.O.G. She had no symptoms, and she was having totally normal periods at that time. The question is, could this have been prevented 4 years ago when she first showed up? Yes, it could have been. She should have had a follow-up to that atypical squamous cell Pap test with a biopsy and presumably treatment of pre-invasive disease. What was her HPV status? We know from the results of that Pap that it was very likely she had a high-risk, high-grade HPV at that time. Did she even come in for follow-up? She doesn't remember ever being told that that was her Pap test result. And what else could have been done after treatment? We'll talk more, but actually, if she had gotten treatment for pre-invasive cancer and even vaccinated afterwards, she would have had very low risk of developing a cancer in her lifetime. So we know that HPV infects a healthy cervix. 90% of those clear on their own without any problem whatsoever. And then of those that progress, about 30% of those who present with precancer will convert to cancer over many years, 10 to 20 years. Now, this timing seems to be getting compressed. Whatever it is in our society, we are seeing more cancers in younger women, women in their early 20s, mid-20s, late 20s, and early 30s showing up with invasive cancer. And this is when it's truly devastating because these women are not just having the fight of their lives to get rid of this cancer, but are often losing their fertility and options for more children in the process. So any HPV carries about a 12% risk of progression to cancer, but if you have HPV 16, we know that that risk is up to 40% risk of progression to precancer or cancer. And that's why the type of HPV matters, and ultimately why we vaccinate against particular types of HPV that cause the most risk for cancer. So the progression of that long amount of time allows us the time to detect that precancer, treat the precancer, and then prevent ultimately it from becoming cervical cancer. A lot of people think that the Pap test, the actual physical act of scraping the cervix to detect these precancer cells, is what prevents the cancer from forming. And I just want to clarify for all of you that that is not the case whatsoever, that the Pap test simply finds the abnormal cells, and then we cut off those abnormal cells, essentially a lumpectomy of the cervix, to then prevent an actual cancer from forming. So that's why we screen more frequently over time. So we don't recommend screening in very young women, because even those women with HPV infections are at much higher likelihood of clearing that virus on their own without any need for extra treatment. In ages 21 to 29, you can do a Pap test alone without an HPV test every 3 years. That's because we assume most 20-year-olds are positive for HPV at some point. If we are going to do HPV testing in 20-somethings, so we actually start at age 25, and I'll come back to that. And then from age 30 to 65, it's a Pap plus HPV co-test every 5 years. And after age 65, a Pap test alone every 3 years is acceptable, but we do not want to screen if they've had adequate prior screening, they haven't had any history of abnormals, no history of DES or other immunocompromise, and not screening after a hysterectomy. So that for some women may actually be before the age of 65, as long as that hysterectomy wasn't because of abnormal Pap tests. So the long-term risk of persistent HPV is really the problem here. And so HPV itself is an important risk factor. And what we want to know, what we need to know, is the woman's HPV status, not just her Pap status. So if you were to ask the question, what about those women with a long-term persistent HPV? What we believe is that actually close to 100% of those women within 7 years will develop precancer or cancer. And that's why we care most about those women who have persistent HPV over a long period of time. So it makes sense that where we are changing our screening is not to ask the question of a Pap test, are there atypical cells there, but rather ask the question, is there HPV there, and how long has it been there? So we know if it's negative, then your likelihood of developing an abnormal cell is much higher. I did see that somebody raised a hand. I'm going to save all the questions to the end. Feel free to type them in the chat, and we'll go through it that way. So if you just get a Pap test alone, there's about a 1% risk in 3 years that you're actually going to come back and have either precancer or cancer in your next Pap test. Unfortunately, I've seen this happen to women that had a negative Pap test. 3 years later, they have cancer. It is devastating to women who've gotten all of their screenings on time, and they always ask me what more could have done. And every single time I tell them, if only we had known if you had high-risk HPV at that time, we never would have let you go 3 years. We would have looked further to see if you had precancer or cancer. And if we actually do a Pap test and an HPV test, the risk of developing cancer 3 years later is only 0.3%. So you've reduced that risk of showing up with a cervical cancer by 70%. One of my professors used to say that the Pap test is the rotary dial phone of the cervical cancer screening world, and the HPV test is the iPhone. You don't want to trust a Pap test. It's a test that was invented in 1940, and you want this newer molecular test that really is going to give you a much more likely diagnosis of whether or not your risk is really there. Is it safe to wait 3 or even 5 years between Pap tests? That's really the question. So we know that including that high-risk HPV gives a 40% decreased risk in the incidence of invasive cervical cancer. And all 4 studies showed similar findings, that if you also have that high-risk HPV test, if you know your status, there are very low rates of precancer, that CIN3 or intraepithelial neoplasia 3, the step right before cancer, regardless of what your Pap shows. And if you have a negative high-risk HPV test, there is a minimum .
Dr. Pierce, we seem to have lost your audio. And you're muted now.
Hi, everyone. I know my microphone has very limited sound on the computer. My phone hung up for some reason. If everybody could be patient with me for a minute, I'm just going to get back on the phone line.
We can hear you through your computer.
Okay. Well, I'll just keep going this way then. Let me go back a minute. All right. So this is a picture of what the various cervical precancers look like, level 1, level 2, and level 3. It is visible, but not necessarily to the naked eye. This requires a special study called a colposcopy that requires a highly trained provider. It doesn't have to be a physician, but a nurse or a nurse practitioner who is trained in colposcopy to look at the cervix with a microscopic exam and then do biopsies to confirm that diagnosis. So this is the process by which we confirm those colposcopies. We look down the length of the vagina with a microscope and a light, and then do a biopsy, a pinch forceps, to get an answer as to what exactly is going on. There are some that appear more obvious than others. The picture in the top right corner is an actual invasive cancer. So we know that cervical cancer is more rare with only 14,000 cases per year, but cervical precancer is unfortunately much more common. So 330,000 new cases of high-grade cervical dysplasia, of which, as we said before, 30% will progress. And the treatment, again, is removing a piece of the cervix. It's not simply a scraping or a freezing, but actually to remove the piece of that cervix that has the atypical cells. If you add in the cases of low-grade cervical dysplasia or HPV infection, those numbers get much higher. By comparison, we know that you diagnose about 240,000 cases of breast cancer every year. So what I remind everyone is that if you know someone who's had breast cancer, you know someone also who has had high-grade pre-invasive cervical dysplasia, and but for these procedures where we cut off a piece of a woman's cervix, those cases would have become cervical cancer. So before we had Pap tests and before we had this procedure, cervical cancer was in fact more common than breast cancer in the United States. And we're very lucky that it's not now, but that doesn't mean that it's rare. It means that every day OBGYNs across this country are fighting this disease, are beating it back at the very border of where cancer forms. And every day somebody's being diagnosed with cancer from a completely preventable disease. So the new guidelines actually take some of this history of a woman's previous screenings into account. And it starts with primary HPV screening at the age of 25. A patient's current test results and past history are taken into account. And then she's placed on this matrix where she's given a risk that she actually currently has CIN 2 or 3, that she has pre-cancer. And then the computer program generates a risk score and recommends the next step in management. So it's all app-based, but anything in that yellow zone or above would result in a woman having either a biopsy or going straight to a procedure. And the reason that this is so important is we know if somebody's in that orange or red zone, they probably should go straight to procedure. Why would you make that process for women, and particularly women who may suffer from difficulty with access? Why would you make that process more difficult for them to come in for a biopsy, wait for the biopsy results, make sure you can get in touch with them to tell them the biopsy results, and then bring them back, when in fact you could do an office-based procedure right at that moment if you knew the risk was high to both diagnose and treat a pre-invasive disease. And so the app, you plug in their age, their HPV status, what type of HPV it is, their cytology, whether or not they were vaccinated, and their last screen. And then you're going to get a recommendation back as to where to go. And you can see in that medium risk, they're still in diagnostic procedures, that yellow, which was in the 1 to 5% range. But anything higher than a 5% risk in that orange to red, you're going straight to a treatment, which are those pictures I showed you earlier of a leap or a cone. So when we look at the risk of recurrence of women who had had one of these procedures, it was actually found in 3 separate randomized trials that vaccination after treatment carried up to an 81 to 85% risk reduction in recurrence. So even if a woman was not vaccinated and developed a precancerous lesion, if you vaccinate her after treatment, her risk of recurrence is lower. Now, that is likely related to risk for pre-infection or reinfection with HPV, and ultimately a reformation rather than a true recurrence. But we know that if everyone is exposed to HPV, what are the things going on in a woman's body that ultimately allow cancer to form? And those include those other risk factors that we talked about. So as we look at screening strategies in context, we can talk all we want about what we should do here in the United States, but the vast majority of women dying of cervical cancer die around the world. And so we need to be looking at examples of strategies that are going to work in very low resource settings. Things like self-sampling, actually a woman being mailed a Q-tip to determine her HPV status and then be called into the office and go straight to treatment. There are opportunities for this, not just in the developing world, but in places that have very low access here in the United States. And those are some of the research studies that we're undertaking now. So current cervical cancer screening best practice. Do you have a primary HPV screening option? So there are limitations to using HPV test as a primary screening, including which tests are FDA approved and whether or not a provider has access to offer a woman those tests. So if not, we still recommend HPV testing plus a PAP. This is not the same as reflex testing, meaning testing those abnormal PAPs to see what the HPV status is. This is testing the HPV status on a normal PAP test to know what is a woman's risk in the next 3 years of developing an abnormal PAP test or a cervical cancer. High-risk HPV positivity means that they have a very high likelihood, I think we said 40% chance that they actually have cancer right at that moment. And so we have to look hard for the disease through colposcopy or even through doing that procedure like a leap or a cone procedure to find the microscopic disease. And as we move further into this discussion, looking for opportunities where you can invite a woman in for a visit, and instead of doing a biopsy, going straight to those treatment strategies for women who are truly very in the high risk category. And of course, considering vaccination after treatment for women who are identified to be unvaccinated and you're treating them for precancer. So how can we provide more services to underserved women? I think this is one of the programs that unfortunately is very underutilized. Unfortunately, many of you know, Alabama has received a grade of F for women's health and is ranked 50th in the country. And we're working hard to improve that, but this is where we're starting, and we've, first of all, got to be honest about it. So we know that there are high incidence and mortality rates in cervical cancer, but this is despite we have an actually relatively average participation in screening. We know that screening has gone down in COVID and we want more people to show up for screening, but there's a disconnect between actually getting the test and still dying of cervical cancer. So we need to look at that space between women who got a test but maybe didn't follow up of an abnormal, need to improve access for biopsies, need to make sure women can get treated, need to add HPV testing both to normal and abnormal PAP tests so we know what their status is and how high risk they really are. And ultimately, we need to look at ways to increase HPV vaccination so these abnormal pap tests and HPV positives don't come up at all. And even if they do, then we can vaccinate after treatment so it doesn't happen again. And there are a lot of opportunities to partner with our Alabama Department of Public Health and others for coverage. So there's a program called Alabama Breast and Cervical Early Detection Program. And that uses state and federal dollars to improve access for women. Alabama Department of Public Health provides the patient recruitment and outreach and pays the provider for services. So I think too often providers believe that the ABC program means that they are providing the services free of charge. That's not true. As long as the woman is enrolled in the program, they will be paid for those services. And unfortunately, what happens is a provider often will do the pap test and then attempt to enroll the patient prior to any type of treatment. That means they did the pap test for free. That's not how this works. You really want the patient to be enrolled prior to ever doing the pap so that the pap is paid, the treatment is paid, and doctors will continue to increase outreach for this program. And doctors and nurse practitioners and all of our primary care. So we know that you can have your registration staff screen for the ABC program. Women who are financially qualified, it's only a series of 5 questions, and our registration staff does it without requiring any financial paperwork from the patient. But it does need to be done before that PAP. And it can include underinsured women whose screening services are not covered by their insurance. So it covers a clinical breast exam, a screening test, the follow-up of abnormal screening tests, which I think is really where the rubber meets the road. Too often women say, oh yeah, I saved up $200 and I'm going to pay for my pap test, but they have no money left if that pap is abnormal. If precancer or cancer is found, the patient does qualify for treatment. But unfortunately, all of those low-grade abnormals do not qualify, and all of those need to be followed up. So it's so important to enroll the patient prior to doing that pap test. Breast cancer is the same. It will pay for repeat imaging, ultrasound, biopsy, and if precancer or cancer is found, the woman qualifies for Medicaid. So it really covers the patient all the way from the moment the screening test is offered all the way through to being cured or in remission of their cancer. Also covered is counseling visits to go with these abnormal PAPs and colposcopy results, treatment for low-grade abnormal PAP tests, as we talked about, and referral to treatment and patient navigation services. In addition to this, every woman who qualifies for the breast and cervical cancer programs nationally also qualifies for something called the Wise Woman program. And this covers heart disease, stroke, and diabetes risk factor screening and a health behavior assessment. It includes counseling and links to community programs, including nutrition, physical activity, and tobacco cessation. So it really is trying to cover women or blanket women with these preventative care services that ultimately reduce a risk, not just for cancer, but for many other important diseases. So we know that we have higher mortality rates, higher incidence rates, increased diagnosis of late stage cancers, and the ability to treat some preventable cancers is at stake for people getting into this program. And everybody has the ability to have better health outcomes if they are enrolled in these programs and get both the treatment and health literacy that they need to take care of themselves. So we need to increase the number of women who are enrolled prior to screening. We need to increase the number of women who participate in the Wise Woman program. We need to increase the treatment of pre-invasive disease and increase follow-up of abnormal PAPs. So if everybody's getting their screening on time, but we still have higher mortality than anywhere else in the country, that means there are abnormal tests that are not getting followed up. And that needs to be a zero event. And we need to increase the number of providers in Alabama who can provide these more specialty services that occur between the abnormal pap test or the high-risk HPV test and actually the diagnosis. And lastly, we're going to talk about prevention of cervical cancer through vaccination. So this is the second case, a 27-year-old with a PAP showing HCell and a biopsy showing cancer. She actually was found to have an 8-centimeter cancer, pelvic exam consistent with a stage 4 diagnosis. Patient was first pregnant at 16. That means she first saw an OB/GYN at 15. That means she was postpartum at 17. All of these ages would have qualified her for an HPV vaccine. Now, whether or not she already had the HPV that would ultimately cause her cancer during that pregnancy at 16, hard to say. But if she had had appropriate vaccination, there might have been a higher rate of clearance and a lower risk of cancer. So vaccine myth number 1, cervical cancer is just not that big of a deal as all the other vaccine preventable diseases. Well, here are the vaccine preventable diseases then and now. If you look at the largest yellow dot, measles, previously at 533,000 cases a year. This was done in 2010 when there were only 61 cases. If you wonder whether vaccines work, since we've had a lower measles vaccination rate, we're now up to 1,000 cases a year in 2020. You can see pertussis, mumps, rubella, etc. These are various rates of disease before there were vaccines to prevent these illnesses. Well, how does cervical cancer rate? Again, measles was the largest at 533,000. If you think of HPV, currently 80 million, that bubble wouldn't fit in this room. But if we look just at cancer, back then, this is deaths from cervical cancer at 175. Now, measles was not deaths, that was only the number of cases. This is the number of cases of cervical cancer and pre-invasive disease prior to the Pap test, at about 350,000 cases every year. So is it as important as every other vaccine preventable illness? Absolutely. And that's just cervical cancer. That's not including the other HPV-related cancers. Where are we now that we have had an HPV vaccine in place for 15 years? All 5 HPV-related cancers together outnumber all other vaccine preventable illnesses combined. So if your child or someone you love was to only get one vaccine in their lifetime, other than COVID, because we're highly recommending that also, and the flu, because that doesn't even count. Of course, you need a flu shot. But if they were to only get one other vaccine, it would be the HPV shot, because this one causes cancer, first of all, and secondly, it outpaces every other one. This is cervical cancer and pre-invasive disease since the Pap test. We don't actually prevent the cancer from forming. We just find it sooner than we used to. So now, instead of finding it as cancer, we find it as pre-cancer. That doesn't mean it does not occur. And we have not yet eradicated cervical cancer. HPV vaccine myth number 2. I don't know anyone with cervical cancer because it's pretty rare. Well, let's just shoot that one down. Everybody knows somebody with breast cancer. It's 1 in 7. And every time I give this talk in a room full of people, every single person in that room raises their hand. But if you divide breast cancer into invasive and pre-invasive, women with DCIS, you can see the numbers here. And every woman with DCIS is told that she has just survived stage 0 breast cancer. And she's a breast cancer survivor, and she wears pink in October, and she tells all of her friends to get a mammogram. Unfortunately, the shame of a woman being diagnosed with cervical cancer does not result in that same outcome of a woman wearing a teal ribbon and making sure that everybody gets their cervical cancer screenings on time and vaccinates their children and grandchildren for HPV. But cervical pre-cancer outpaces breast cancer and pre-cancer combined. So if you know someone with breast cancer, you know someone with cervical cancer, pre-invasive or invasive, stage 0 and up, as the number is 1 in 6. HPV vaccine myth number 3. We're not sure it works. Well, that's just dagblame not true. So we actually have really great data that shows a significant decrease in the rates of HPV among young people after vaccination. And this did not occur across the board. The unvaccinated group saw a small but insignificant decline, but a 61% decrease in those vaccinated in the late teens and a 71% decrease in those vaccinated in the early teen years. And this is true for males and females for HPV and pre-invasive disease, as well as for genital warts, as the only available HPV vaccine on the market in the United States also prevents genital warts, and a significant decline was seen in the vaccinated group, while no change was seen in the group greater than 30 that was not vaccinated. This shows a significant reduction in the risk of precancer among vaccinated women. And ultimately, here's the data on cancer. In the group of vaccinated women from the earliest cohort in the Norway area, there were 0 cancers in the vaccinated group compared to 10 cancers in the unvaccinated group. And in total, they saw a total risk reduction in cancers across the board. HPV vaccine myth number 4, that PAPs are just as good at preventing cervical cancer, so we don't need to vaccinate. You all got this answer right on the quiz. But just to show you the data, if we look at PAP tests only, we will only ever get to 80% improvement in reduction in risk. If we only vaccinate, we get to 90%. But if we want to prevent 99% of these cancers, you have to do both. And that's where this spacing out of PAP tests come from, that if you do both screen and vaccinate, it doesn't make a difference if you get a PAP test once a year. If you get it every 5 years, it really has shown that it's a very, very high rate of prevention of cervical cancer. And lastly, myth number 5, I have concerns about HPV vaccine safety. I understand everyone having concerns. When there's so much misinformation on the internet, it is hard to know what is true. The vaccine has been on the market for 15 years now, and I can tell you with extreme assurance, the HPV vaccine is safe. The safety studies have been done. They're very reassuring. It included 106 studies in 2.5 million people around the world. It is as safe as every other vaccine. And to date, we have not observed any signal that shows that it causes any of the things that it has been accused of causing over the internet. And I think, like many other misinformation campaigns, we've seen that with a lot of vaccination misinformation that unfortunately has resulted in a decrease in vaccination across the country, including people not feeling comfortable taking the COVID vaccine. And I just want to reassure you that it is in everybody's interest to make sure these vaccines are safe before they ever go on the market. The HPV vaccine was studied in over, I think, close to 80,000 people over 10 years before it was released on the market. And now that we have 15 years of post-marketing surveillance, we're now at 25 years of information. We know for sure that it's safe. So we know it's safe. We know it works. We know that that protection lasts. And we know that we are under vaccinating here in Alabama. Our HPV up-to-date rate for our 13-year-olds is only 19%, which is well below the national average. So we need to vaccinate girls and boys ages 11 to 12. You can vaccinate as early as 9. We want our preteens to finish the series before 13. So it's 2 shots total for children that start the series below the age of 15. And then, of course, any girls and boys up to age 26 who have not started or finished the vaccination. And then there is a consideration for vaccination in people who are age 27 to 45. This is an individualized discussion that should occur between the patient and the provider to see if they would be a good candidate. The number one reason parents don't vaccinate for HPV is because it's not recommended. And this is where we can all partner with our primary care physicians to make sure that people hear from us that we recommend it. I tell everybody I was vaccinated myself at age 30. I plan to vaccinate my girls as soon as they're old enough. And I strongly recommend it to any of my cancer patients to make sure they tell their families, their children, their grandchildren to get vaccinated. And all of us can play a role in making sure that those of us who know the data and are in healthcare strongly recommend it. I will point out to you that each of these is also a misinformation. So not sexually active, of course, we want to vaccinate before they're not sexually active. So this is a great time to vaccinate. Safety concerns and side effects is really just providing people with fact-based information that there is no reason for safety concerns, and the major side effects are pain, redness, and swelling at the injection site. That it is not needed. I think hopefully we have dispelled that myth that we know HPV is one of the highest risk diseases and most common diseases that is vaccine preventable, and it is strongly needed. And of course, lack of knowledge. That's what all of these represent, and we want to make sure we get the right information out there. Provider recommendation for vaccination. We know that if providers recommend it, that the uptake is 75%. But if nobody recommends it, the uptake's only 40%. That means you're making the parent or even the child do all the work. And any provider counts. The OBGYN for mom can recommend for the kids. They don't necessarily have to do the vaccination. A pharmacist can make that recommendation if they're also vaccinating adolescents for other vaccines, and a dentist who is seeing higher rates of oropharynx cancer in their patients can make that recommendation to a child to, get back into the pediatrician's office and get that vaccine. And the most recent NCI consensus statement of all the National Cancer Institute cancer centers encouraged all healthcare providers to be advocates for cancer prevention by making a strong recommendation for childhood HPV vaccination. We ask providers to join forces to educate parents, guardians, and colleagues about the importance and benefit of HPV vaccination. And so what we ask of all of you is to be a champion for the HPV vaccine. The obvious ways: giving presentations, sharing medically factual information on social media, recommending it to people who may be unaware or unsure, and helping us to connect HPV cancer survivors to advocacy opportunities. And maybe the not so obvious are ways that we can advocate for policy change and coalition building through our cancer center and through other means. I just want to point out this beautiful photo of the Mobile skyline lit up in teal and white for our annual Go Teal and White Day, which was January 13th this year. And Bill Starling, our fabulous USA Health photographer, who captured this under duress at sunset last week. I wanted to conclude to say that the burden of HPV-related disease continues to increase in Alabama and the United States. Screening with a PAP is not enough. We have to increase access to HPV testing, follow-up services, and HPV vaccination, and we all can do more to improve those vaccination rates, including starting in your own sphere, use social media, build partnerships, and be a resource for your family and friends. With that, I'll take any questions.
Dr. Pierce, I'm going to launch the poll again because we want to measure knowledge gained. So we're going to launch the second poll. It's the same one you've seen. And then we'll dive into Q&A. I know there's some in the chat box already. Feel free to.
All right. The first one: my kids received the first HPV vaccine. Now that the new vaccine covers more HPV strains, will there be a push to get them revaccinated? No. The good news is if your children were completely vaccinated with the first vaccine, then they do not need the second. The minimal increase in added benefit is in the less than 20% range, and they should be good with the first one. When we did a study looking at types of HPV in precancer compared to cancer, there were many different types of HPV that caused precancer, but every cancer that we looked at had HPV 16 or 18 in it. And so I really feel strongly that as long as they got that first Gardasil 4, they don't need to be revaccinated. Is this done automatically, or do you have to request an HPV test? That's a great question. Unfortunately, in many places around here, you still have to ask for that HPV test. And if your doctor says, yes, we do reflex testing, say, I don't want reflex testing. I want to know my HPV status and my PAP status. And do make sure to ask it when you call back for your PAP results. A lot of women really aren't getting that information. If it's within 30 days of the PAP, they can still send an HPV test on it. So ask twice. I've talked till I'm blue in the face to OBGYN providers around the state and around the country to make sure that they're ordering the HPV test, and yet there still seems to be a disconnect, which is why we're taking this on a road show. My daughter is 10. When do I ask her doctor about the vaccine? Now's a great time to ask a doctor about a vaccine, and you could plan. There are a lot of adolescent shots. It's a 4-shot visit, and not every 11-year-old wants to get 4 shots in one visit. So HPV is a good one to get early. And others you actually have to get on time in order for insurance to cover it. So you could start the HPV series at 10 and then have 2 more adolescent shots at 11, including the second HPV shot, and then 2 more at 12. So make sure you get all of those adolescent shots in before those more important things that adolescents do, like going to camp and things like that, which is why we recommend those other adolescent vaccinations like the MMR booster and the Tdap booster and the meningitis shot. What are your thoughts on recommending regarding HPV testing during pregnancy? So generally, the more recent recommendations for cervical cancer screening during pregnancy mean stay on your current screening pathway. So if you have a PAP and HPV test prior to pregnancy that are negative, there's no reason to repeat those during pregnancy. If you are not up to date on your screening at the time that you present for that first OB visit, you absolutely should become up to date by getting those tests in early pregnancy. So yes, a woman can get an HPV test during pregnancy the same way that she would. And those guidelines, of course, will be different in terms of what you do about that positive HPV test. Almost always any type of biopsy or treatment could wait until after the pregnancy is over, but that's a very individualized discussion, and I see women and counsel them on that regularly. Do we get CEUs for training? Great. I do not believe that this is a CME or CEU presentation, but I will defer that to our organizers if you send them an email. It looks like we're about 43% of participants. And I think now our scores are even higher. I'm going to go ahead and end the poll so everyone can see that and share these results. Screening in the absence of primary HPV screening begins at age 21. So that is correct. PAPs are just as good as false, 100%. I'm so proud. There are symptoms of cervical cancer in early stages, not typically. Boys and girls that are already sexually active still need the HPV vaccine. So false is correct. What are some of the reasons parents don't vaccinate? All of the above. And early detection of cervical cancer increases women's survival rate. How many women can be saved if the disease is caught and treated early? Almost all women, if we can catch cervical cancer and treat it early, can be saved. So that's what we hope for. And I really appreciate everybody's attendance today. I'm happy to take any other questions, but if you're good, then we're done. Thank you. If at this time you wanted to unmute yourself and ask your question live, go for it.
I had a question, Dr. Pierce.
Sure.
Since one of the survey questions discussed getting the vaccine if they're sexually active or before, how is sexual activity linked to HPV?
So HPV is transmitted through any skin-to-skin contact. So that includes all the various ways that people have sexual intercourse. Kissing, the jury is still out on kissing, but we know that oral intercourse can transmit HPV. And so, unfortunately, because it is skin-to-skin contact, barrier contraception is good, but not perfect for prevention of transmission of HPV, which is, again, why we so strongly recommend the vaccination.
I'm sorry.
Go ahead.
Were they just trying to catch the kids before they become sexually active? Is that why the age, or
actually that's a great question. The most important reason that we vaccinate at an early age is because your immune system reacts more strongly, and therefore you only need 2 shots. So you get a higher antibody response and more protection if you're vaccinated before 15 compared to after 15. And so that's the reason that it is in the adolescent group rather than earlier. Unfortunately, for many teens, 15 is a time when they're already experimenting with sexual acts, even if they're not what they would consider to be sexually active, and doing things that could cause HPV transmission. But that's not the main reason. The main reason is this much higher bump in antibodies, and therefore they only need to get 2 shots instead of needing to get 3 shots if they initiate the series after 15.
Thank you.
Okay, great. Thank you. Anybody else? Okay, great. We'll end on time. Thank you everybody for coming. I really appreciate your engagement, and we hope you'll partner with us. Thank you.